Well, first of all, I am Claire. I am the research lead at Mindset Health, and we're really excited to be putting this webinar on. And it's part of our educational series for healthcare providers. And we're especially lucky to be joined by Dr. Stephanie Bayliss today. Dr. Bayliss is a naturopathic doctor with a private practice in Victoria, British Columbia, focused on the intersection of women's mental and hormonal health. Stephanie is a Menopause Society certified practitioner and a faculty of the Confident Clinician, a training platform designed to empower naturopathic doctors to translate research into evidence-based clinical practice. She's passionate about educating healthcare providers, and we're really lucky to have her here today presenting on non-hormonal therapies for menopause-associated vasomotor symptoms. So with that, without further ado, I will pass it over to you, Stephanie. I am just going to quickly touch on a couple of housekeeping things. We will have a Q&A session at the end of this, timing dependent. But if you have questions throughout, please check them in the Q&A box. So there's the chat, which you're welcome to use throughout the whole presentation to interact with the participants who are live. And then there's a separate Q&A box, which on the right-hand side of the screen has the little question mark. So if you click that, that's the Q&A box. That's where we'll pull the questions from at the end. So feel free to check those in there. And then in terms of getting CE credits, we will send out an email after this. So just check your email for that. And yeah, I will pass it over to you, Stephanie. Thank you so much.
Awesome, Claire. Thank you so much for the introduction. So I'm here today, everyone, to talk about vasomotor symptoms. And really, this is something that 80% of women will experience in their life, and they last on average for 7 years. Right now, the conversations are super heavily weighted towards menopausal hormone therapy. And yep, for sure, that is definitely the gold standard and ultimately most effective treatment. But there's certainly a subset of people who either have a contraindication or choose not to go on it. So this presentation today is to just try to add some more tools to your toolbox. This is the fancy long title, but we're going to go into evidence-based approaches for treating vasomotor symptoms. So as Claire said, I'm Dr. Stephanie. I'm a naturopathic doctor, Menopause Society certified practitioner. I am also the co-founder of Metaverse, which is an online platform for women to learn more evidence-based information related to their health and cultivate online community. And also the Confident Clinician. So this presentation is very evidence-based in its approach, and it's very similar to the work that I do with the Confident Clinician in terms of giving people up-to-date patient protocols to try to make your life just a little bit easier, because clinicians' lives are very busy. I practice in Victoria, BC. I also want to acknowledge, with respect, the Lekwungen people on whose traditional territory I'm practicing on, and the Songhees, Esquimalt, and Wasandish people whose historical relationships with the land continue to this day. I also think it's worth acknowledging, like, scope of practice everywhere is going to be a little bit different. So I'm in BC, Canada, so I do have prescribing authority, so I can prescribe most pharmaceuticals. Where you are, you might not be able to do that. I think that I am talking a little bit about some pharmaceuticals at the end, and I believe that that's important, because I think even if you can't prescribe them, people are still going to be rolling into your clinic on them, and so it's a really good idea to have an idea about what they are and how they work. This is a brief overview of what we're going to talk about. So I've divided out the treatment options into 4 areas. So mind-body techniques, dietary and herbal interventions, some lifestyle things, and then we will, like I said, talk a little bit about pharmaceuticals. I've packed a lot into this. So as I said to Claire earlier today, I'm going to try my best to get it done in an hour and then also leave time for Q&A. So we'll see how that goes, but I'm also happy to stick around for a few extra minutes at the end too. I'm also going to frequently be using the word woman throughout the presentation, and that really just reflects the data that is available and ultimately the lack of data on vasomotor symptom management on non-binary and gender fluid individuals, which is certainly an area that needs to be researched more. And when I say women, I am speaking about cisgendered individuals in general. This is the formal learning objectives that we had to put together for the CE application. So not relevant. I'm not going to be talking about that, but that's an overview of what we're going to be talking about today. So basically, as I said, like up to 80% of women will experience vasomotor symptoms. And, 20% of them could easily have more than 7 in a day. The standard of care, as I said, is menopausal hormone therapy. And I will be referencing the North America Menopause Society, now known as the Menopause Society's position statement. So their 2022 position statement on hormone therapy stated that, menopausal hormone therapy is the most effective treatment for vasomotor symptoms alongside like genitourinary symptoms. And it's also been shown to prevent bone loss and reduce fractures. I will be referencing their latest position statement, which came out last year on non-hormonal options. And so I'll be referring to that throughout. And I recommend if you do want to learn more, that's a great document to pull up. And so who will this presentation benefit, right? Because most people are probably going to go on menopausal hormone therapy if they are having hot flashes or night sweats. Really, this is for the people who have contraindications to it, or maybe just choose to avoid it, or just ultimately don't tolerate it. And really, there's, we're saying now like up to 1 in 8 Canadian women will develop breast cancer during their lifetime. So that's huge. And then also, when people get breast cancer, they're living for much longer, which is amazing. But we also need to expand treatment options to be able to support them during that time. I wanted to also just include a little bit about the contraindications to menopausal hormone therapy. I mean, there's many potentially, but those are just the ones that the Menopause Society endorses. I know for me, my comfort level with people is I usually do just a really good risk-benefit analysis. Obviously talking about and screening for some of those things there on the slide. Okay, so we're going to start by talking about mind-body techniques. And so the first one that is probably the most long-standing, but also the most well-researched is cognitive behavioral therapy. And essentially, if you don't know, CBT treatment, it really just involves helping people change their thinking and behavioral patterns that are unhelpful and potentially contributing to their symptoms. It really places a strong emphasis on helping individuals learn to be their own therapists through exercises that they do in session with their therapist, but also like lots of homework between sessions. It's really focused on trying to like break down some of those like problematic thinking patterns and how that might be contributing to their symptoms overall. Specific to menopause, there's actually been a protocol developed called CBT Meno, which is essentially a published manualized treatment designed to target a variety of menopausal symptoms. So not just hot flashes and night sweats, but also things like depression, sleep, anxiety, even some things about like urogenital concerns and sexual concerns as well. It's the 12-week course, and there's 2-hour sessions each week across those 12 weeks. And it's a group that the research studies are done, they're in groups of up to about 8 people. And then there is like some homework between sessions. And so it has like this particular protocol has been studied a number of times in a variety of different ways. And it has been shown to reduce the degree to which vasomotor symptoms are rated as a problem. And then also improve a bunch of other things. So we've seen significant improvements in things like vasomotor symptoms, depressive symptoms, sleep difficulties, and sexual concerns. What's great is that those improvements are maintained over a 3-month period. I also really think it's worth acknowledging that there is in general a huge risk of depression during this change and transition. So we know women are at a very high risk at this time for a variety of reasons, like life stresses for sure, but also the hormonal fluctuations. And so CBT is something that has been very wide, long-standing as a treatment for depression. So I do think it's a really great one to add to the toolkit. And we do see, like the last sentence there, improvements in problematic beliefs about menopause, and then also dysfunctional attitudes related to depression and menopause-specific behaviors. So those would be things like, sometimes you'll hear people say, like, when I have a hot flash, other people think I'm incompetent, or they start like changing their behavior. Like maybe they stop taking certain work opportunities or presenting at work because they know when they do that, they're going to have a hot flash or they're at risk of having a hot flash and they're embarrassed about that. And so we just see how like our thoughts impact our behaviors, which impact the reality. And so CBT is really just trying to like break that down. And I would just encourage you, if this is something you're interested in, there are like training programs that you can get trained in how to offer this, but also there's likely groups local to where you are. And so seeking those out and just having those available is a good option for people. Mindfulness is the next mind body technique. And so I will say I'm biased on this. Like, I do really believe in mindfulness based interventions for all sorts of things. And there's tons of evidence showing benefit, not just for mental health concerns, even for things like blood pressure, which is really, really amazing. And so the most widely standardized and studied form of mindfulness is MBSR, mindfulness based stress reduction. And it's an 8-week group intervention involving a combination of meditation and yoga. It's a 45-minute to 60-minute a day commitment for 8 weeks, which people often like completely balk at, which is completely reasonable. And essentially, the point is to really try to encourage people to observe the present moment and just really get in touch with what's happening in a non-reactive, non-judgmental way. There's also a silent meditation retreat at the halfway point. I will also say, like, for those 8 weeks, you will strive to do the 45 to 60 minutes a day, but then afterwards, there is this acknowledgement that people generally don't keep that up, but maybe their practice reduces by, like, 30 to 40%, and so there is, like, lots of long-term benefits from even meditating, 2 to 3 days a week. It doesn't need to be daily. So I usually try to, like, preface it to patients that you don't have to do this forever, but it's at least dipping your toe into the full thing is a good idea to just learn how to do it. There's been a couple of studies done on mindfulness. The first one specifically for evaluating hot flash and vasomotor symptom improvement was done in 2011. And so they did show that there was quite a big improvement. So in reduction in the intensity and the number of hot flashes and like how bothered they were. Something you're going to hear me say a lot during this presentation is that a lot of the research is just not great. And one of the pieces is this here is so it's being controlled to waitlist controls, which is not like a true placebo group because those waitlist control individuals could have been seeking out therapy. We don't know. It's not adequately being assessed for that. But even still, it is showing some benefit, which is really great. And then beyond that, there was a meta-analysis done more to try to evaluate the impact of mindfulness-based therapies on the overall menopausal symptoms, so not just hot flashes and night sweats. And we did see that it does improve things like quality of life, but there really was insufficient data to analyze vasomotor symptoms. So I'm very much looking forward to this being another tool down the line. But at minimum, we know it helps other things, right? Like depression and anxiety. So it could be an appropriate recommendation for many. Now, the big thing that I'm excited to talk about, but obviously that's related to mindset health. So it's funny because when I was preparing this presentation, Claire was so great. She's like, you don't have to talk about the EVIA app. You don't even need to mention hypnosis. Like, only if you feel like that's appropriate, like no pressure, which I really, really respect because obviously this is like being sponsored by them. But I am including it because I do think it is really helpful and it is something that I'm recommending to my patients. So I always like to, first and foremost, many people don't even know what hypnosis is. And so clinical hypnosis is a mind body therapy that involves a deeply relaxed state and individualized mental imagery and suggestion. And so it has a pretty long historical use for other things like pain, anxiety, migraines, not just things like hot flashes. But there's been a couple of trials exploring its use in hot flashes, both showing like some really reasonable results, which is amazing. So the most recent one was done in 2013, and it was a single-blinded RCT like 187 postmenopausal women who were having at least 50 hot flashes a week, which is a lot. And so they were measuring hot flash frequency, both subjectively, meaning like the patient's report of how many hot flashes they were having, but they were also actually doing like physiological recordings to monitor things like body temperature. And so what we saw was a pretty significant reduction in the hot flashes across time. So you can see like the solid line is the control group, which was the control group for this study was something called structured attention. So they really try to match the same principles as what people would get with the hypnosis, except there's no hypnotic inductions or like cooling suggestions provided. It's just only like a therapist relationship in a therapeutic environment and like some exchanges between the participant and the therapist. So, like, that didn't really work at all. As you can see, the line is basically straight. And then we can see with the hypnosis, it did improve. And then even at the follow-up, there was still an improvement, which is really great. And then similarly here, this is just like another representation of the data. So baseline, endpoint, and then the follow-up was at 12 weeks. And so those effects maintained, which is really, really amazing in my mind, given that it's such a short intervention. And so the EVIA app is like a 5-week evidence-based hypnotherapy app. The link is there, but essentially patients, it's a 15-minute commitment per day, which that is doable for people. Like, I feel like that's something people are like, okay, fine, I can do that. But some of those other interventions like mindfulness, where it's like 45 to 60 minutes, is a tall order. And so just to see that even after doing this for 5 weeks, we'll still probably see maintained benefits at 12 weeks is pretty great. And then the North American Menopause Society does endorse it as being like a level 1 recommendation, which is amazing. So this is, I think, something definitely to be including in your recommendations. I thought it would be worth mentioning like who maybe would not be appropriate for a referral to a clinical hypnosis program. And so in the studies, the individuals that were excluded rather, were those with a history of psychosis, borderline personality disorder, or another type of serious psychopathology. And in those situations, I would just want to consult with psychiatry or psychologist and see if it would be an appropriate recommendation for them. Also, side effect wise, generally it's really well tolerated. In those RCTs I mentioned, there was no adverse effects that were reported other than some like mild skin irritation from the electrode that they were using to monitor skin temperature. So that's amazing. I think Claire can probably speak to this more, but I'm going to do a very like brief job about why does this work. We don't really know, but at this point, our thinking, first of all, we don't totally even know how hot flashes and why they are happening. There's likely multiple physiological reasons for that. But the thinking is that hot flashes are a result of some autonomic dysfunction. And so a theory that's been proposed is that potentially, a reduction in parasympathetic tone is contributing. And so with the hypnosis, we do see potentially an improvement in parasympathetic tone, which could result in the improvement in the hot flashes. This is an area that should definitely be studied widely, and we should be monitoring things like heart rate variability and that stuff. So I look forward to learning more about that in the future. Last mind body technique I thought I would mention because it's included in the North American Menopause Society position statement is like paced breathing and relaxation. So like basically it doesn't work, and that's no surprise, right? And like if a patient was sitting in front of me having 7 or more hot flashes a day and I was like, I just think you should take some deep breaths and like try to relax, like that's just not going to go over very well. It's a great way to lose a patient. So but what I will say is that like many patients do tell me, Steph, like when I'm getting a hot flash, if I do just try to like relax and breathe, maybe it doesn't last as long or it's not as intense. And I do think just like educating patients on grounding strategies and breathing techniques, like that can be useful, but that's certainly not going to be enough to manage someone's hot flashes. So in summary, on those mind body techniques, encourage you to expand your referral network, like get in touch in terms of like local CBT and MBSR groups, possible hypnotherapy groups locally. We do see improvements in vasomotor symptoms with CBT and hypnotherapy, less so with the mindfulness-based interventions, but they do help those other things like quality of life and anxiety and depression. And then the paced breathing and respiration is not recommended. Now I'm getting to the good stuff. So this is the dietary and herbal pieces. And so I just really want to say, as I've already said, like I'm going to reiterate, and I'll probably say it a few more times, the research sucks. And I'm doing as good of a job as possible in terms of pulling out the parts where it's like, okay, this seems promising and this is something I use clinically, versus like so far the research on this is not very good. And so I'll point you in the right direction in terms of the things that I do use in my practice and that there is like a large degree of safety data on. The big thing is that, like, anytime we're trying to study hot flashes, there's just this massive placebo effect, so it makes it really challenging. So most of the studies, as you've probably already noticed, like the placebo group has this like 20 to 50% improvement in symptoms, which is unfortunate in the sense that like it makes it really hard for us to find out. We're asking, it's a tall order for these interventions to work better than that. It also emphasizes, though, why we need these randomized controlled trials because of how big of an effect there is in placebo. Now, like NAMS, their non-hormone therapy position statement from last year basically doesn't recommend any of the things. So they say, like, pretty strongly not recommended across the board, everything from soy to herbs, supplements, and cannabis, all included, not recommended. So I'm going to speak to that and sort of, again, tease out where there's some nuance there and populations where we might want to be considering using them. First of all, the one that I think is the most important is phytoestrogens. And this is where we see probably the most amount of, I would say, a bit of like misinformation and general confusion. So in general, phytoestrogens are a very broad group of compounds. They're in like literally hundreds of plants. So everything from like legumes all the way to fruits and veggies. The one that's most commonly focused on is soy. So the reason for that is that they are probably the strongest in the sense that they have a really high affinity to the estrogen receptor beta, and they have both like estrogen agonist and antagonist properties. So firstly with soy is there is a metabolite of soy called a qual, and that's likely the thing that's providing the most amount of benefit when we're talking about isoflavones. It's a potent estrogen receptor beta agonist, which is part of why it's so effective. So if someone eats soy, they end up getting like a molecule absorbed called daidzein, which then our bodies have to take daidzein and transition it into a qual. And the qual is the thing that is going to be the most effective. Now, approximately only 35, some studies say 20, but it's like 20 to 35% of North American women can do this. 50 to 60% of Asian adults can do that. Likely, they think the difference for that is really due to the dietary differences and ultimately differences in gut bacteria, but we don't totally know and understand that. The other thing is we don't, like, in terms of testing and to see who can absorb soy better than others, those tests are not commercially available at this point, to my knowledge. But that might be something we see down the line as like better able to tease out who is going to be more useful for them to increase soy in their diet. Now, there are some studies, which I'm going to talk about, that have been done evaluating supplementation with the Equal directly as opposed to just soy isoflavones. And the ones that where we're supplementing with Equal, they do seem to be a little bit more effective. But the problem is that like the studies themselves are not even always assessing who is an Equal producer and who isn't. So it gets a little bit messy, but I'm going to try to unpack that a little bit better for you. So the most recent systematic review and meta-analysis from 2019 did find positive effects supplementing with a qual over placebo in 3 of the 5 trials that were studied. The 2 that were null findings, that was really just because the thinking is that, first of all, there was a really small number of participants, like less than 50. And then in one of the trials, there was actually differences in vasomotor symptoms at baseline between the control group and the intervention group. And then the biggest trial only included Equal producing women, which that's not very helpful given the point of supplementing with Equal is to try to bypass that metabolism problem. So we should probably just be giving it to everyone. Anyways, I digress. The variation in dosing was from 10 to 49 milligrams. And I just wanted to include that there. So if this was something you were thinking of giving patients, you had that dosing in terms of what was reflected in the research. It's not really widely available. Like I cannot really find local to me and a qual supplement. There is, you can Google it. There is a company that is offering a qual supplements. It's quite expensive. It's not something that I've used clinically yet, but I'm like hopeful that there is a little bit more availability of those products because I do think that that would help in terms of us seeing more benefit from soy in general. Now, this study is interesting, and I wanted to include it because it's really recent. It's just from the end of last year, 2023. So this was a dietary intervention where they actually gave women soy, and that really was a half a cup of cooked, non-genetically modified, like the most perfect type of soy you could imagine, equating to about 55 to 60 milligrams of isoflavones. They provided the participants with instant pots or pressure cookers to cook the soy, which I thought was really interesting. The recommendation was also to avoid animal-derived foods, so like definitely gearing them more towards like a vegan diet, and then trying to minimize the use of like oils and fatty foods, even things like nuts and avocados, which I thought was a little interesting. But I was really excited to see that they said like a maximum of one alcoholic beverage per day. There was a 1 hour weekly group meeting with a registered dietitian on food prep and dietary adherence. And I'm just noting that because I always like to mention what they do in these trials. Because in clinical practice, we give patients a handout that says, here's the diet you need to follow. Like, I'll follow up with you in 2 to 3 months. And oftentimes people need a lot more handholding than that. So that's something to consider if you're recommending a big dietary change in this population. So the total hot flash frequency in the intervention group reduced by 78%, which is huge, and then only 39% in the control group. But like I laugh because that's still a really big reduction. But the between group differences was still significant. There was actually an 88% reduction in the moderate to severe vasomotor symptoms in the intervention group. They also lost 3.6 kilograms of body weight, and there was an improvement in other measures, so like mental, emotional, and sexual domains too. So the ability to convert the daidzein to a qual did not seem to influence the intervention's efficacy. So both the qual producers and the non-producers saw benefit. But the big problem with this study was that they only took of the 84 women, I believe it was 12 that they evaluated whether they could do that conversion appropriately. So I think that's a really bold statement that they're saying that there was no differences in who benefited from it. But I'd like to see this study like be repeated in like a much bigger population where we're evaluating whether they can actually do that metabolism appropriately. So conclusion, this is definitely something I am encouraging people to add soy products to their diet, but you are playing the long game. And there's a summary slide coming up here, but essentially we think that when you add soy in, it does seem to take about 12 to 16 weeks before people will notice a benefit. And probably there is some differences in terms of who is going to get more benefit from that than others. Other types of isoflavones that you might be aware of are like the isoflavones in red clover. So there was one human trial in patients with breast cancer who were on tamoxifen who took red clover. They had 80 milligrams of red clover extract daily for 2 years, alongside a Mediterranean diet with physical activity in both groups. So this is tricky because what ended up happening in the results is that like everyone got benefit. So there was improvements in hot flashes, sleep, and fatigue in both groups. So even the ones who didn't take the red clover. So it's really hard for us to say. But what this study did help us understand is that there probably is, based on this, it's reasonably safe to take red clover isoflavones alongside tamoxifen. That's why I wanted to include it. And then there was a 2015 systematic review and meta-analysis looking at the red clover isoflavones and the studies that have been done on it. And so this might be hard to see, but you can kind of get the point. If you're familiar with reading a forest plot, if it crosses 0, it's not significant. So basically none of these are significant except the one over here. But what they did see, like the conclusion, even though the data was crappy, is that they did see somewhat of a reduction in hot flash frequency, but the effects were much stronger in those who had more severe hot flashes, which they rated as more than 5 per day. So, in spite of the data being not great, the Menopause Society doesn't even acknowledge it as a treatment option. It's not in that position statement. But I would say for me personally, if someone is not able to take MHT, this is something that I am recommending with some really good informed consent. And I'm okay with doing like a trial for 8 weeks just to see if they find benefit, and just letting them know that the research studies, minimal adverse effects have been reported, but the mixed results is something worth noting. Flax seeds. So one of the main components of flax seeds is lignans, which have the phytoestrogen piece in it. There's metabolites of lignans, which are enterolactin and enterodiol, both of which are anti-estrogen, and are actually structurally similar to estrogen, and they can bind to cell receptors accordingly. And so there was a systematic review done in 2015 where they basically concluded that, yeah, the current evidence does suggest that consuming flax may be associated with reduction in breast cancer. And it seems that even flax potentially has anti-proliferative effects in breast tissue of women who are at a higher risk and who may protect against primary breast cancer. And that's at a dose of about 25 grams of flax seeds per day, which is 2.5 tablespoons, about, depending how big your heaping tablespoon is. So it's a lot of flax. I also think it's worth mentioning, which I didn't put on the slide, there was another interesting study where they gave patients who were recently diagnosed with breast cancer a 25-gram flaxseed containing muffin or a control muffin. And after 1 month of the intervention, the researchers found that the ones who were getting the flaxseed containing muffin had a 34% reduction in cancer cell proliferation and a 31% increase in apoptosis in the flaxseed group compared to the placebo group. So that's pretty cool. And this is definitely something that I'm encouraging, especially my patients with breast cancer, to be including in their diet. Observational data does suggest that flax seeds may be protective against breast cancer, as I said. Like the research is pretty poor when we're thinking about using flax seeds to reduce hot flashes. The studies are pretty mixed, and the amount of flax that they're using is really varied, like 7.5 grams to 40 grams. One of the RCTs, the benefits weren't greater than placebo, which could be for a variety of reasons. So how confusing, like what the heck with all these phytoestrogens and the confusing research. So this is what I do, is I do educate my patients on increasing soy protein in their diet, aiming for 1 to 2 servings per day. I do recommend adding 1 to 2 tablespoons of ground flax per day if it's reasonable. That's also not just for like the hot flash benefit, like it also is really great for bowel and digestive health. And just going back to the soy, that's the same thing, right? Like many of those studies were also including the Mediterranean diet. Soy is certainly a part of that. We also see soy be a part of the portfolio diet, which helps in terms of cholesterol reduction. So both of those things are really like safe and reasonable interventions for people to add in. Just keeping in mind, like if you're hoping the soy is going to help the hot flashes, it's probably going to take a long time, up to maybe 16 weeks in some cases. And then generally, I'm gearing most of my patients towards the med diet, as I said, so reducing saturated fat intake and then obviously increasing vegetables. Now, black cohosh, this is another like really contentious herb, and so I'm going to do as good of a job as I can breaking it down for you. So the Menopause Society, remember, they've said in 2023, not recommended, and they did evaluate black cohosh. We don't really know completely how black cohosh works, but what I will say is the research that I'm about to show you, it's pretty mixed, and there certainly are people who benefit from black cohosh, and there's definitely some studies where they do show benefit. The Cochrane review was done in 2012, and they concluded that there was insufficient evidence at that time. However, there was enough evidence for them to say we need to do more studies. And so from 2012 to now, there's been a lot that have been published. And so the position statement from the North American Menopause Society came out last year. And then like, I think almost like a month or two later, there was this pairwise meta-analysis on black cohosh that came out a couple months afterwards. And so this is not like, and so basically my question is, if the North American Menopause Society was to reevaluate their position, knowing what this pairwise analysis says, I don't know if they would change their mind, but this pairwise analysis does show improvements. And so I'll just orient you to this table, but essentially on the left-hand side, we've got the different outcome measures. So overall severity, hot flash, somatic symptoms, anxiety, and depressive symptoms, and then dropout. If you're not familiar with like the Hedges G coefficient, that's basically referring to effect size. So what you can see here is that they were reviewing like all the studies, and then they've done a subgroup analysis of the products that were using these like compound black cohosh. So maybe it's got like 5 other herbs in there and black cohosh, or just black cohosh alone. And so what you can see is that the overall severity and symptoms improved with the black cohosh, as well as the hot flashes. And it didn't really matter if it was in a black cohosh compound or if it was on its own. It was not significant, the difference between those two groups. So yeah, this is really great. We do, like I said, improvement in overall menopause symptoms, as well as in hot flashes and somatic symptoms, but it isn't clinically significant, statistically significant rather, for anxiety or depression symptoms. Now, so like safety is another big thing that comes up for black cohosh. So what we see, like the conclusion at this minute, which could change, is there's no evidence to date that suggests that black cohosh use increases the risk of recurrence in women with estrogen receptor positive breast cancer. There's been 3 randomized control trials in women receiving tamoxifen. Varying in length, but 60 days to 12 months. 2 of those studies, worth noting, did see a reduction in hot flashes, but there was no concerns of harm or recurrence in those studies. A meta-analysis from 2021 published in the Climacteric Journal, which if you don't know, that's the journal of the International Menopause Society, they concluded that black cohosh as a non-hormonal herbal therapy can also be used in patients with hormone-dependent diseases who suffer from iatrogenic climacteric symptoms. So they're essentially in that statement endorsing it as an option. Hepatotoxicity or liver toxicity is another one that we often hear about and are concerned about. So a meta-analysis from 2011 of like 1,100 women basically said that this is not something we should be worried about. Now, I will say, like, this is something I'm concerned about, but not just about black cohosh. I think about this for all herbal therapies is contamination, and quality control is a huge issue. And so when if I'm going to be using black cohosh, for example, I want to make sure that it's like been third party tested. The company is reputable. It's like a 40 milligram capsule, doesn't have a bunch of other herbs in it. And then if someone does choose to take it, the research studies would say generally there's minimal adverse effects and it's generally pretty well tolerated. And it is worth noting that it's safe with tamoxifen. Okay, so a couple more herbs to go through. These ones are going to be far briefer because there's just less research on them, but rhubarb is one. I'm not that excited about rhubarb, although I will say, like, rewind 5-6 years ago, this was something I did on odd occasion use in my practice, and did see some benefit. But mostly where we probably see benefit, I would say clinically, for me at least, is there's this like really strong placebo effect that happens, as I've mentioned before. And so in my experience, when I've ever used this in the past, is it can work for the first little bit, but then the effects taper off. The couple studies that have been done have been industry funded. I do have the name of the product on the slide just because there's only one. And they did find benefit, and in like the total menopause ratings score, more menopause symptom score, and also in vasomotor symptoms. But it's hard because there was like a huge dropout rate, like only a 12% retention. So there's some problems with that. There was also another recent one done in 2021, and it was a single harm study, so it wasn't compared to anything, but they did report improvements in menopause symptoms with that product. Sage is one that I'm excited about. It's worth noting that it does have some phytoestrogens in it. I suspect and anticipate that this will be one that's going to be like more spoken about and more research is going to come out. Worth noting, it wasn't even mentioned in the North American Menopause Society statement, but there was a systematic review and meta-analysis that was published last year. They reviewed 4 studies. In total, there was 310 women in them. All 4 studies separately indicated that sage did reduce the frequency and severity of hot flashes in the postmenopausal women. Now, when they pooled that data together, the frequency of the hot flashes in the postmenopausal woman was significant compared to placebo in terms of frequency, but not in terms of severity, unfortunately. So it sort of leaves a little bit to be desired there. What I would say is the dose that's most commonly used is a 100 milligram compressed tablet of sage 1 to 3 times per day, and really minimally reported side effects. So this is again something that I on the audication will use. If all the other things that are way better than this are not available to us, this is something that I am comfortable using, especially just given how safe it is. There's no studies that I was aware of using it in conjunction with tamoxifen, so that wouldn't be a part of my toolkit at this point, but not to say that the research isn't going to evolve on that. Vitex or chasteberry berry. So before I dive into the specific stuff about the vasomotor symptoms, I just want to mention that this is an herb with a wide degree of safety when we're thinking about PMS symptoms or premenstrual syndrome. So if I have a patient who is like perimenopausal, but also experiencing some PMS symptoms, this is something I'm very comfortable adding in. It is actually like pretty widely accepted as a treatment option. For vasomotor symptoms specifically, the data sucks. There's been 4 double-blind RCTs looking at the Vitex for the vasomotor symptoms. The problem is the doses vary like hugely, like 50 milligrams to 1,000 milligrams. The strength of the extract is different. I wish we could just all get on the same page about what we're doing, but anyways, the largest trial that was done had 100 women in it, and they compared a mixed supplement of Vitex, so it had other stuff in it, to placebo. There was no benefit for vasomotor symptoms, either in frequency or intensity after 4 months. 3 smaller trials with less than 50 women did find benefit, but they were questionnaire data, so they weren't like diaries. So the difference would be like, hey, how many hot flashes did you have last week, as opposed to tracking your hot flashes in a diary daily. And so they did see improvements in bother and intensity levels after 8 to 12 weeks of treatment. Uh, Worth noting, like minimal adverse effects. So this is something I am comfortable trying, especially if there is that like coinciding PMS symptoms happening. Omega-3 fatty acids. So this is obviously, I think it goes without saying, this wouldn't be a great recommendation if someone is having hot flashes, that the only thing you're going to do for them is give them omega-3s. There's certainly many other things that we would be thinking about. There might be other potential benefits to omega-3s, or rather I'll rephrase that, there are other potential benefits to omega-3s, but certainly not on its own for vasomotor symptoms. Oddly enough, we have actually studied this a couple of times, once in 2009 and then again in 2020. And so with similar amounts of EPA, which I always like to see, like that's a reasonable dosage. And so in this particular one, after 8 weeks, there was no change across the board compared to placebo. There's also the Ms. Flash trial, which I'm going to talk a little bit more about in a minute, because there was a bunch of different arms to that study. But in that one, there was no benefit. Actually, let me rephrase this. So number one, there was benefit in this one, but there wasn't benefit in this one. So kind of confusing, and not so totally clear in terms of why we would get benefit in this situation, but not in this one. But obviously, this is a much bigger trial with 350 women. So yeah, if the effects were there, we probably would have seen them. Evening primrose oil, 2 randomized control trials have been done looking at this. And so the 2021 study gave 1,000 milligrams of evening primrose oil twice a day, and the other one gave 500 milligrams before bed. And so, like, long story short, essentially, the one where we did it twice a day for 8 weeks, there was a reduction in frequency and severity of the night sweats compared to the control group, and that was statistically significant. And then similarly with this one, they took the evening primrose oil just before bed. There was no, it wasn't better than placebo for hot flash frequency and duration, but the severity of the hot flashes was significantly better compared to placebo. So not how long they lasted, not how many they had, but the degree of severity did improve. So this is something that I would say isn't personally in my toolkit, but if one was reaching for some ideas, this might be an idea to use in terms of night sweats specifically, and then severity of hot flashes during the day. So, in conclusion, when we're thinking about the herbal nutrient interventions, we've got black cohosh, we've got sage. Black cohosh is probably the best out of all of them. And then sage, rhubarb, omega 3s, like chaste tree vitex. If there's going to be some co occurring premenstrual symptoms, it may be worth trialing. And then the evening primrose oil may decrease the frequency and severity of night sweats specifically. Okay, so now I'm going to dive in. I'm doing pretty good for time, so we will see if I get how much further I get. So lifestyle intervention. So avoiding triggers. They're like the common thing is we give people a list of like, okay, you're going to avoid these things to try to improve your hot flashes or night sweats, or these are some of the triggers you might experience. Well, there's actually no clinical trials evaluating the effectiveness of avoiding those triggers. And I would say it's also like pretty awful to be like, okay, to manage your hot flashes and night sweats, you should just like avoid spicy food or hot foods and liquids for the next 7 years. Not really realistic. The one that I will like strongly endorse and the hill I will absolutely die on is that increased alcohol consumption worsens vasomotor symptoms. And I'm sure you've heard about that clinically with your patients. Also, it's a carcinogen. And so, thinking about breast cancer risk, this is definitely something I'm counseling my patients on reducing. And then the cherry on the cake is that it will also help their vasomotor symptoms. Exercise. So, there's a mountain of evidence showing that exercise is great for so many other health benefits, but it's really not a great standalone treatment for vasomotor symptoms. And that's probably because it's really hard to study, and the types of exercise vary, the length, like there's a whole bunch of problems. The other thing is that like exercise can trigger hot flashes. So these like poor women who are in studies, it's a mixed bag. There really has not been any consistency demonstrated that exercise helps vasomotor symptoms. And as I say in the last point here, a few observational studies show it helps, and then a few have found no relationship. So it's pretty mixed. And then there was a Cochrane review done on this in 2014. And again, they concluded evidence is insufficient, no evidence of difference between groups in terms of frequency or intensity of vasomotor symptoms. It's certainly not something that would be a great recommendation on its own. And then we've got the MIS Flash trial. So this kind of summarizes a few of the different interventions I've talked about. So this study had 4 arms with like 4 randomized controlled trials looking at 6 different interventions. And so there was a couple of drugs, which I'm going to talk about in a bit. And then we had CBT for insomnia, oral estradiol, exercise and yoga as like one intervention, or omega 3s. And so it was pretty big, and they looked at like a number of these factors. And there was different check-in points, but it varied between like 8 weeks to 12 weeks. And so essentially, no surprise, the oral estradiol reduced the vasomotor symptoms the most. And then the escitalopram and the CBT also showed some benefit. But overall, the benefit of all of those interventions I just mentioned was pretty poor. And so this summary table speaks to that. And so I'll just point out the more important pieces. So along the top here is like the check-in points. So week 4, week 8, and week 12. And then, so trial 1 was escitalopram. So we can see that at week 8, there was like a 0.6 reduction in the menopause quality of life questionnaire. And so if you're familiar with that questionnaire, that is like really insignificant, like really, really, really insignificant. And then exercise and yoga at 12 weeks, like really like 0.2 reduction, 0.5, really, really poor. Omega 3s, same thing, didn't make a difference. It actually got a little worse. And then estradiol was the most promising with a 1.2 reduction in symptoms of the vasomotor. And then the venlafaxine was not very effective. The escitalopram was more. But the CBT for insomnia did actually reduce the score overall the most at 0.7. Now, I want to just spend a minute talking about an exercise prescription because I do really believe that there's an art to this. And when we give patients recommendations like, oh, you like this is the guidelines in Canada, it's you should exercise 150 minutes a week, moderate to intense severity, and like also throw in 2 45-minute strength training workouts. And it's like patients just don't, they just can't do that. That's a huge lift if they're not doing anything. And so it's really important to spend some time with your patients thinking about like how to motivate them and hold them accountable in terms of movement goals. And so when you're having this conversation, you want to think about like what are they actually going to be doing and what do they actually like to be doing? Maybe there was some things that they used to do when they were younger that they really enjoyed and we could like think about bringing those back in. I always like to write this down with them, right? And maybe you're having like a separate appointment to talk about the exercise goals, but like how long are they going to exercise for? What day of the week are they going to exercise for? And so I always like to get very specific. So it's like, okay, you're going to exercise Tuesdays at 4 p.m. right after work before you pick up your kids from daycare. You're going to go to the pool. You're going to do 30 laps. Perfect. You're going to talk about how intense it's going to be. So there's like the specifics, right? You're going to do 30 laps. And then like after a month, you're going to try to increase that, or, you're going to swim this many lengths and this much time. It's also important to talk about like what are the barriers. I think this is the thing that we often forget is like, well, what happens if your kid's sick that day and you have to pick them up early from daycare? And it's like, oh, great, I don't exercise. So coming up with backup plans is key. So it's like, okay, maybe your backup plan is you're going to get home, put your kid in front of the TV for 30 minutes. So you can do a yoga video online. And like that, at least that's the bare minimum of movement that you're going to do that day. It's also good to bring in and encourage the patient to think about accountability partners and cheerleaders, like who is going to be moving them along. Certainly you, but also maybe they're going to get their best friend to do it or their husband. And that way it just makes it a little bit more accountable for them and they'll probably be way more likely to follow through. And then think about what an appropriate follow-up interval is. So these studies where they're doing an exercise intervention, they're getting like check-ins with a trainer or their doctor like weekly. It's not just something that's happening, every 3 months. It should probably be more frequent. And then you can certainly guide people towards like the SMART goals, which is just another way of thinking about coming up with the specifics around goals. Now, weight loss. I didn't even really want to include this in here, but I felt like I should, just given that's included in the Menopause Society position statement. So, really, like the trials that exist are really small, they're not randomized, and they're usually post hoc. So, like afterwards, they're like, oh, we're going to go back and try to see if there was an effect there in terms of weight loss. We do see that gains in body fat have been associated with greater odds of vasomotor symptoms, but essentially, like the data is super limited. And I would just say, like, this is not, it wouldn't be an appropriate recommendation for treating people for their hot flashes to recommend that they lose weight. I think that why are they getting benefit when they lose weight? Well, is it because they're exercising? Is because they changed their dietary pattern? In one of the studies, it was suspected that the reason why people got improvements in their vasomotor symptoms was because of the medication they were using to lead to some weight loss or to help them lose weight. So it's just really it's a conversation that you want to be very delicate around. And I'm just always encouraging people to find love and movement and activity as opposed to really making the conversation specifically about weight. Acupuncture, multiple systematic reviews and RCTs have shown acupuncture to be helpful for many menopause related symptoms, mood, sleep, pain specifically. We're not seeing as great data on vasomotor symptoms. A 2018 umbrella meta-analysis did find some modest benefits for the use of acupuncture for reducing vasomotor symptoms when compared to no treatment. But when the acupuncture was compared to sham intervention, it was no longer clinically significant. And a big thing that just comes up time and time again, which you might be aware of, is that there's been a lot of debate in terms of what we should be using as a control group in these acupuncture studies. And so many have argued that the sham intervention might not actually be physiologically inert and isn't an appropriate comparison. And so what we'll see, and I saw in much of the data on this, is like better than like a placebo pill, but not better than a sham acupuncture intervention. Now, this is the most recent meta-analysis on acupuncture, and so what they found is that they looked at 17 studies with 1,100 participants, and so the efficacy of traditional TAs, traditional acupuncture, and EAs, electroacupuncture, was higher than that of sham acupuncture and significantly higher than that of placebo. Electroacupuncture was just better across the board compared to traditional acupuncture, and electroacupuncture was better than sham acupuncture. Traditional acupuncture wasn't necessarily on its own better than sham acupuncture. So this is something that you think about then, is that referrals for acupuncture would be a great idea for many reasons, right? Like there's all those other benefits for menopausal symptoms, but it might also help vasomotor symptoms, especially if it is electroacupuncture. It's worth noting that those studies, they were like at 1 to 2 treatments a week for 8 weeks. So it's always important to set expectations in terms of how much time it's going to take to get some benefit. So, in summary, you might want to consider discussing triggers with your patients, but most importantly, talking about an alcohol reduction. Exercise, amazing for many reasons, but certainly not for vasomotor symptoms. Same with the weight loss piece. And then, really, just like I said, approaching those body composition conversations with care. And then acupuncture. So, electroacupuncture is better than traditional acupuncture for vasomotor symptoms specifically, but there's probably some other benefits that we're seeing in terms of mood, sleep, and pain. Okay, so closing this out in the last couple of minutes here is pharmaceuticals. So the menopause position statement does recommend SSRIs and SNRIs as like a level 1 recommendation for treating vasomotor symptoms. The ones with the most amount of evidence are here for you, and they're the ones that have limited evidence are here. So you wouldn't be using these. We would be using these ones if we are going to do it. And so I always think that it's worth mentioning, like, because the conversation doesn't go great when a patient comes in and can't take MHT, and you're trying to brainstorm some ideas, and then you're like, okay, I'm going to give you an antidepressant, and the patient is like, well, I'm not depressed, like I don't want that medication, and so it needs to be handled delicately because really we're not giving it for its antidepressant effects. We're giving it because it seems to do something in terms of thermoregulation, but we don't really understand that. And so, again, as I mentioned before, we also don't understand precisely the physiology of vasomotor symptoms either. There's a variety of theories out there, but I do really think like cushioning that conversation with a patient is going to really help compliance because they're certainly not going to want to take it if they don't think they're depressed and you're giving them an antidepressant. But we do also see that those who have moderate to severe vasomotor symptoms tend to have a depressed mood. They think that's in large part because they're not sleeping from their vasomotor symptoms. So, all in all, of course, if we support vasomotor symptoms, we would expect mood to improve. And that's what we would see in the research too. So, clinically, if you are going to give an SSRI or an SNRI, some expectations to be clear about is like generally the clinical response is quite fast, like within a couple of days, as opposed to if I'm giving an SSRI for a depression, we would say it's going to take weeks to see an effect. If one drug doesn't improve hot flashes, it's reasonable to try another one after 1 to 2 weeks because we would have already seen it to be working. SSRIs and SNRIs are both effective for relieving vasomotor symptoms. There's not really been any studies comparing the two classes. Certainly, SNRIs have more side effects. So, in most cases, starting with an SSRI would be appropriate. Venlafaxine, though, is the preferred choice if women are on tamoxifen because SSRIs do interfere with tamoxifen. So that's a really important one to just be aware of. And then, how are you going to choose which one you start, right? Like there's a list of the ones on that previous slide that are recommended. And so really it's about shared decision making with the patient and thinking about the side effects. It's really common for me to like bring up the table of all the side effects and work it through with them, which of those side effects they're a little less fearful of or not as important to them. And then generally, SNRIs are associated with more adverse effects, and they're also harder to get off of for the most part, so more withdrawal and discontinuation symptoms. Want to be thinking about cost, and they also want to be thinking about what are the other goals. So, do they have co-occurring anxiety or depression? Is there sleep challenges? Are they on other drugs? Like you want to bring all of that into the conversation. And then finally, these are some of the other prescription options, which I'm not going to talk about each of them in great detail, but these are the ones that the Menopause Society and like FDA has endorsed. Some of them have many other uses, of course, like the gabapentin and the clonidine. Oxybutynin is a treatment for overactive bladder syndrome, but it does also help vasomotor symptoms. I wanted to just spend a minute talking about the last one here, fezolinetant. So this is a newly FDA-approved medication, and it's an oral medication for the treatment of moderate to severe vasomotor symptoms. We have seen in the RCTs that there was a pretty significant reduction in hot flash and vasomotor symptoms. Big thing with it is it's super expensive. So it's like $2,500 US about a year. So really, really expensive. And the other thing is there's some pretty hefty side effects associated with it, specifically concerns around liver enzymes. So, but again, I am glad to see that there's more options becoming available. And then in terms of summary, so all together here, so CBT, mindfulness, clinical hypnotherapy are all going to be good options, recommending increasing soy and adding ground flax, reducing alcohol, mixed research on all those herbs, as I said, but probably black cohosh and sage are the most promising. SSRIs, SNRIs associated with some good improvements for mild to moderate hot flashes and night sweats. Exercise, not a good recommendation on its own. And then if you're going to recommend acupuncture, electroacupuncture would be the better option. So thank you very much for listening. This was like I did a rapid fire piece here, but I'm finished right on time at 2 o'clock.
Fantastic. I certainly learned a ton, and I know I've seen a couple comments, but I think that was really amazing for all the healthcare providers that were here and that will watch the recording as well. I do have a couple questions. I know we're basically out of time, but I'll do sort of a couple rapid fire questions and
Go
then
for
we'll
it.
wrap up. The first question I had was around, you spoke about so many different studies for everything from the dietary interventions to the herbs. And I noticed that there was such a big variability in the timelines of these studies. And it seems like there's not a good consensus on what an appropriate timeline for follow-up in this menopause population for vasomotor symptoms. Can you speak a little bit about that and what sort of an appropriate timeline for follow-up in these studies really is in this population?
Yeah, that's such a good question, Claire. I mean, I guess mostly we want to be comparing it to the thing that works the best, right? Which is the MHT. And, oftentimes many people in those situations will see improvements within 3 to 4 weeks. Sometimes, of course, it can take up to 3 months, but it can be quite rapid. So probably we should be following people though, like all the way to 12 weeks just to see that we're like getting out of that placebo effect time frame. And then I think it would be even better if we followed them longer and like did a 12-month follow-up too to see if like people are actually sticking with the black cohosh because it kept working, for example. But yeah, there's so much variability. And I would say clinically, I'm generally following up with people in like 4 to 6 weeks, depending on what the intervention it is that I'm giving.
That makes sense. The next question I have is around misconceptions. I think this is an area where there's a lot of myths, there's a lot of misconceptions. Can you speak to some of the biggest misconceptions that your patients come to with and how you're addressing those?
Yeah, that's a good question. I would say one of the biggest ones is soy. Like they think I'm wild for being like, okay, you should increase the soy in your diet. And that's the one where I'm really happy to debunk just from like many perspectives, as I said, not just for the hot flashes, but for all the other potential health benefits. And then also there's just so much misinformation and ultimately bad information about hormone replacement therapy too. And so really happy to like sit down and like go through the literature with the patient and talk about the risk versus the benefits. And same goes with all of the other stuff that I've mentioned today. Because really, it's so important for patients to feel like the thing that they're doing works, right? Like if they don't believe it's going to work, that impacts things a lot. So it's really important to educate them and spend the time doing that.
Awesome. Last question. A lot of these things that you've spoken about, whether it's, dietary interventions or herb supplements, and, a lot of these things are quite pricey for patients. How do you take into account socioeconomic factors of patients when making recommendations?
Oh, it's such a good question. That's something that I feel like super, super strongly about because oftentimes naturopathic doctors and I think other healthcare practitioners too will be like, okay, here's the like 10 supplements that you should take for, ever more and not really consider the cost piece to that. And I think that's really quite problematic on many levels. And so I am certainly often recommending like this is the brand and the type, but like please shop around and find the cheapest thing that you can. And then also just being really clear around expectations. Like I'm putting you on X, we're trying it for 8 weeks. It's going to cost this much to do the trial. If it doesn't work at 8 weeks, we're ditching it. Like this isn't something you're just going to like take and then be on forever. And then also it's just like these things aren't covered, right? Like it's drugs are the things that are covered by generally here anyways, by extended drug coverage. And so it's balancing that, right? Like if I'm sitting in front of someone and it's like they're a lower socioeconomic status and the drug like an SSRI is covered, but the black cohosh isn't, it's like, okay, well, I guess we're probably going to be doing the drug because that's the cheaper option. And it's going to be more financially sustainable for them to do that.
That's a great answer. All right. Well, I will wrap it up here. Thank you so much for your time. It
Thanks,
really
Claire.
was fantastic. We will send out the recording. So if you've missed it live, you're more than welcome to go back and watch the recording. And then, like I said, just watch your email for information on either the self-directed CBD if you're not a naturopathic doctor, or if you are a naturopathic doctor, a C credit. So again, thank you so much. Have a wonderful rest of your day. And thank you, everyone who is here live as well.
Thank you, everyone. Bye, Claire.